So JR is our patient today. He is a 31-year-old Caucasian male who presents to the clinic with the chief complaint of headache and stuffy nose. So some of the differential diagnoses that we could be thinking of would be migraine headaches, viral upper respiratory infection, or viral versus bacterial sinusitis. So JR is stating that his headache and nasal congestion have been ongoing for approximately 10 days. He was exposed to someone who was sick prior to the onset of his symptoms. The headaches are typically located in the anterior aspect of his forehead, but radiate into the bilateral eyes and into his left cheek, causing some tooth pain as well. So the headaches kind of come and go. They're like a constant dull pain, but when he changes positions, he finds that the dull pain turns into a sharp shooting pain. He's been taking Tylenol and ibuprofen and alternating them as needed for the pain, which helps to alleviate some of the symptoms temporarily, but it doesn't completely fix them. And he's also taking some Benadryl at night to help with the nasal congestion, and he states that it helps him sleep a little bit. So for the review of systems, he does endorse an intermittent fever. It typically runs from 100.1 to 100.2. Although the Tmax over the 10 days was 100.5. He denies any unintentional weight loss. So for the head, eyes, ears, nose, and throat, he endorses pain and tenderness over the bilateral eyes when he pushes on it, and kind of just looking around in the bright light bothers it. He denies any changes in his eyesight. He does endorse some stuffiness of the nose and notices a thick yellow drainage in the bilateral nares. He states that the stuffiness is worst in the morning and when he goes to lay down to sleep at night. He also endorses the occasional tooth pain on the left side of his face. He denies any throat pain or pain with swallowing. He denies ear pain, ear drainage, and then respiratory-wise, he denies shortness of breath, chest pain, or any sort of cough. Neurologic, he does complain of occasional dizziness that is worse with the position changes, but denies change in mental status or level of consciousness. He denies changes in speech or motor function. So for JR's past medical history, he does have stage 1 hypertension, in which he takes lisinopril 10 milligrams by mouth once a day. He also has von Willebrand's disease type 2. Family history, his father has been diagnosed with hypertension. His maternal grandmother has been diagnosed with congestive heart failure, and she's had an NSTEMI in the past. And then his maternal grandfather has had a STEMI. He denies any surgical history. Social history, he's never been a smoker, but he does state that he did chew tobacco and quit roughly 10 years ago. He drinks 1 to 2 beers per month and denies any illicit drug use. He is allergic to cephalosporins, in which when he takes that, it causes a rash. So for the physical exam, general-wise, he was well-nourished, well-kept. Head was normal cephalic. He did have the tenderness over the frontal sinuses bilaterally, and he had some mild tenderness over the maxillary sinus on the left. Nose, I did see the thick yellow drainage that he was talking about. It was present in the bilateral nares. There was some erythema at the base, and I didn't see any nasal polyps. For his ears, the tympanic membranes were pearly gray and they were opaque. Bilaterally, there was no drainage or erythema. Neuro, he was alert and oriented ×4. He had an appropriate mood and affect. For the lungs, they were clear to auscultation in all lobes. He had a regular rate and rhythm. And cardiovascular, since I was listening to lungs, I took a quick listen to the heart, and he was regular rate and rhythm. S1 and S2 were heard, and there were no murmurs present. So per up to date at this point, we wouldn't need to run any diagnostic tests yet. So our diagnosis at this point would be acute bacterial rhinosinusitis. So pharmacologically, we would start thinking about beginning amoxicillin 500 milligrams 3 times a day for 5 days. We would tell him that he could continue taking the Tylenol and ibuprofen as needed for the pain if he felt like it was helping. And although this is not an up-to-date recommendation, if he felt like the Benadryl was helping him to sleep, he can continue taking the Benadryl as he needs it. Another thing that we can recommend for him would be beginning the use of a nasal saline spray to help with some of the congestion symptoms. So as far as patient education for him, the big thing that we want to educate him on is antibiotic adherence. So we want him to take the full course of antibiotics for the full 5 days. We really want to talk to him about, he may start feeling better between the 48 and 72 hour mark. And that's when a lot of people stop taking the antibiotics. So we want to make sure that he knows to take it for the full 5 days. Every single pill needs to be gone. We can also talk to him about increasing hydration during this time and proper hand hygiene so he doesn't continue to spread the illness. So some follow-up recommendations. So since he should be feeling better within the 48 to 72 hour mark, we can tell him to return to the clinic in 3 to 5 days if his symptoms have not improved after starting the antibiotic. At that time, we would consider, we would want to make sure that this is the correct diagnosis. So at that time, we can consider doing a respiratory viral panel or ruling out other diseases. And if we are sure that it is acute bacterial rhinosinusitis, we can possibly bump up the antibiotic regimen to amoxicillin clavulanate or a higher intensity antibiotic.